Okay. I'm sure more people will join, but I just want to thank everybody for getting up early. It's so nice when you're home and you're able to get your stuff done, and these are on Zoom, but when you're giving the presentations, it's you do truly miss being in person, and I wish I could be there and interact with you guys all in person this morning. So if you have any questions or anything about what we talked about this morning, please just jump in. It's informal. This is a fun talk. I thought it'd be good for the 7 a.m. slot to wake everybody up. And it's about cranial surgery and kind of some of the work we're doing here at UM and some of it of my opinion of what it's going to look like in the year 2050. Here's the disclosures and funding. So, I like to start with this slide when we look at this kind of technology adoption life cycle together. And if we plot kind of the evolution of cranial neurosurgery on this, we could kind of talk about some of the major kind of developments, which there hasn't been many in the last 40 years. Things like navigation, the microscope are obviously mainstays now for cranial neurosurgery and had a huge impact quite a while ago. Recently intraoperative neural monitoring, and now even more recently in the last 10 years, LIT and robotics have really kind of come through the evolution. And I would argue that almost every academic center now has robotics and LIT for cranial neurosurgery. Some of the newer things such as augmented reality, artificial intelligence, and spatial computing are a little bit more on kind of the upslope. There's some high expectations. We're not really sure where they are going, and we're still kind of trying to work them into the workflow. But I think what's most interesting, and when you look at this slope, is that if I plot each one of these separately on a time graph, the time it's taken to adopt each one of these is getting shorter and shorter. And these days, with the use of virtual meetings and webinars and social media and everything being online, as soon as a new technology comes out, it's almost adopted very, very quickly. And, our residents and medical students today, the amount of new devices, techniques, surgeries that they are learning and adopting in residency is tremendously more than any of us have done in the past, and will continue to go faster and faster as this cycle shortens and shortens as time goes by. One of the most obvious examples of this is ChatGPT. This came out now less than a year ago. An AI website that basically uses artificial intelligence to answer any question that you would ask it. And within a week, it became, the most accessed website ever, trumping Google and Yahoo and everything in that time period. So it was like the fastest website to get to 100 million users, and there's a bunch of statistics on this. But I've given this talk now a couple times to us grand rounds, and I'm excited to give it here today. But I thought maybe I should check with ChatGPT real quickly and see what it thought. What would be the biggest changes in neurosurgery in 2050? And it kind of actually came up with some very obvious answers. A lot of them are in my talk today, which is good. The ones that aren't in my talk today, I'm still reassured that we are working on here at University of Miami. And so I think we're on the right track here if you look at our research portfolio, which is exciting. So the goal today is really more to stimulate the residents and medical students here. You're the future of neurosurgery. How you will develop, interact, combine, influence, and initiate this kind of technology in their practice is really what's going to make the difference in the future. My time is almost kind of on the downslope, and so this is kind of trying just to inspire you. So the areas that I wanted to talk about today are really the use of artificial intelligence, spatial computing, and virtual reality and mixed reality, which are all kind of the same thing, robotics and big health data, and how they are influencing medical education, preoperative planning, intraoperative workflow, and postoperative treatment. And I like to start with this slide that I've now stolen for now 5 years from Timur, where it's the Black Panther, and this movie, I'm sure you've all seen it by now. They're talking about a futuristic time period in 2018 in Wakanda, and a futuristic lifestyle and technology kind of culture. And the American who's visiting has a vertebral fracture, and they're using this medicine here to kind of virtually look at it. And what's cool is that a year before that at Timur was actually doing something very similar when he was first working with the AR system here during spine surgery and actually looking at the anatomy while surgery was ongoing. And so sometimes you just it's a great kind of influence of the future is closer than we think it is, and these things are happening more rapidly. And even when you see something in the movies, it's most likely because it's actually something that's really happening in real life. So when we talk about medical education and the use of some of this technology, there's really probably a decade ago now, there was this big kind of onslaught of the use of virtual reality and augmented reality for medical education. And this has actually been quite quickly adopted by medical schools, in that I would say a lot of them have foregone a cadaver lab in lieu of using this kind of technology, which is a shame because I think there's no real replacement for a cadaver lab. But working together with them, I think that you could see that there's a huge amount of education that could happen with visualizing the 3D anatomy in real time and having access to it at any time point during the day, with everything labeled and kind of correlating to something you're reading in a book. Neurosurgery has adapted this also. Now, I mean, this is again a very old picture of UCLA back worse when surgical theater came to tuition. This is when Neil Martin was still at UCLA. It's like, probably a decade ago. This ability to kind of share this virtual reality and 3D anatomy with residents, medical students, and patients in order to understand how the surgery would go, how to plan the surgery, and really just how to discuss it with each other for educational purposes. Since then, these models have gotten much better. This is Alexis Morella, one of our fellows, who is using a Metavis system, which has some of the best kind of virtual reality graphics. And you can see in the bottom here, I mean, this is a CTA reconstructed with shading, and this is what it would actually look like as you were kind of looking at the brain and planning kind of the anatomy. It's almost like realistic if you take out the brain, you just look at the arteries. And so the graphics has gotten much better. It's gotten much faster, and it's much easier to kind of share information and use it for educational purposes. And interesting enough, the urology department here at just got a huge donation and purchased several of these, one of which we're going to be able to have access to. And so you guys will be able to actually start using this now for anatomy and education, as well as in the OR. And more details of that will come shortly. As far as simulations go, this is again an old film from about I don't know, CNS, like 09, maybe 09 or 2010, where they had this simulation lab where you could go and use virtual reality with kind of a mock suction and CUSA to try to simulate the fine nuances of resecting too fast and blood control. And this model really never kind of cut off. I mean, I think this company still makes this, but it was a very cool idea with trying to get some tactile feedback and models to actually practice surgery. Since then, we've been working with another company called Upsurgeon. Caroline and I have done several labs with this technology in the lab, and the idea is that you can use multiple modalities. So you start with first virtual reality, then you go to augmented reality, then you go to a model with augmented reality, and then you finally go to cadaver. And so, instead of just getting to the cadaver once and trying to go through the anatomy with a book, this is much more interactive. You're learning in 4 different kind of modalities. And the thought is that you retain information much better when you see it kind of in 4 different ways. And that will help you kind of learn faster and retain more information. Their models are incredibly realistic, and they're growing significantly. We have the aneurysm model here, the endoscopic model as well. And, you're able to do the dissection of drilling. You're able to go down and clip an aneurysm and actually visualize some of these key components. They just came out with some new spine models, which are incredibly realistic, where you could do an ACDF. You can actually resect the disc, drill down the bone. You have actually pulsating carotids that are nearby, and if you get into them, it will bleed. And there's the fat actually kind of is oozy. It's like the textures of the anatomy are just kind of incredible. And this is really kind of where this practice modality is right now. And their company is expanding tremendously fast. They've expanded now beyond neurosurgery to breast and GI and colon and prostate cancer for these kinds of models to kind of practice specific parts of the case. But that's now. So where are we going in the future? Well, as we get more interaction with this technology, with augmented and spatial computing, this ability to kind of sense and interact with the model as you work with it will become more realistic. So, for instance, you could have an aneurysm rupture model, and you'll have things like it'll monitor how much pressure you put on the brain, how much your eye moves, how many times you place your hand in and out of the field, how fast your hands are moving, how long it took you to get to the aneurysm, how long it took you to clip it, did you have to adjust the clip? All these things will be automatically tracked by kind of this visual technology and using the model. And then you could kind of train yourself, and you could have somebody like Seth versus Dr. Morkos, and try to see if you could measure up to a legend's kind of hand and motor techniques, and how their heart rate and blood pressure will react when there's an aneurysm rupture. And you go over this over and over and over again until you finally kind of match what is the exact gestures and skills needed to master this specific area of neurosurgery. And this model is being built right now, so we'll be here very soon. So if we move more into the preoperative planning area, again, there's no question that there is some role for augmented reality in cranial surgery. I mean, we've been using it here in Miami to kind of look at different ways that it can be used. This is a project with Timur and Dan Eichberg, where we were planning neurosurgery and comparing it to the navigation system, and showing that, yeah, you can actually kind of see the tumor, where the vessels are, what is the correct entry site, how to make the most minimally invasive incision. And we showed that it was just as efficient as using navigation. But if you think a little outside the box, this is a great
pain has been progressive.
Great video from Walter Jean, where just kind of a novel way of thinking about how to use this for surgical planning is that a very simple case, an MVD, but instead of thinking about it in its usual way, what he did was basically look at where the compression is on the inside of the patient's head, and then plan the surgery inside out. So here he is looking at the SCA compressing the cranial nerve 5, and then looking at exactly where he'd want his entry site to be. And then actually he's able to make the opening from the inside out at the transverse sigmoid junction, and then kind of go out and then look at it from the outside in. Then take that exact plan, that minimally invasive plan, and target it, and then kind of go from an outside in during the surgery using that plan that he just generated from inside out. Again, not a complex surgery, but you could see just kind of, there are some different ways that you could kind of use this technology to optimize and make your surgeries more minimally invasive. So that's now. Where are we going in the future? This is something that was just released by Dr. Goodall Cohen, called the Atlas Pathfinder, which basically is another virtual reality system where you could upload your patient's information, their lesion, their brain and their brain tumor. It'll identify where the lesion is, and then it'll actually recommend different approaches. So it'll say, okay, this is a deep lesion that's right on the lining of the ventricle. The two approaches, transcortical or interhemispheric, or contralateral interhemispheric, and it'll tell you kind of the path lengths, what are the critical structures along each path, and is there cortical spinal tract? Are there vessels? What are the risks and benefits? You could change kind of the model to suit your area. And then you could actually bring this, he refers to this as a kind of a cone of safety. So if you chose your approach, you have your cone of safety, and you could bring that into the operating room field. And if your microscope drifts outside the cone of safety, basically an alarm will go off and tell you that, hey, you're drifting towards the cortical spinal tract, or you're drifting towards the MCA, or you're drifting towards an area of unsafety. So it's kind of one of the first ideas of where in cranial surgery, where you could have a system that will actually start alarming you on where areas would be. And you could take this and do the virtual surgery in a virtual OR, position the patient, go through the actual case before we actually get to the operating room, go through the whole case, and then bring it to the operating room. So, this idea of, when we think about, the Navy or the Air Force, when they train their pilots on test flights and test missions, and they're able to go through things ahead of time and kind of using almost these video games, this is becoming more and more realistic for neurosurgery and our training pattern in preoperative planning as we move forward. So if we move towards, the intraoperative workflow, I'm sorry, I'm going to skip through this. So again, this ability to have 3D vision, just like Dr. Roten always used to tell us, have X-ray vision while you're visualizing the anatomy, try to look past what you could actually see. Well, now using this technology, this is a great clip from Mount Sinai where they're using it during an endoscopic case, which is one of the great examples in cranial neurosurgery because you have very minimally exposure and you don't see a lot of the anatomy, and you know that there's critical structures like the A1s, the ACOM junction that are beyond you, and being able to kind of see that either next to you or actually overlaying it on top of you provides you some rest assurance of how much more you need to go and where those critical structures are. There's another company called VizAR Novarad that we're also kind of working with, and they're one of the first to get FDA approval on the cranial side for navigation purposes with augmented reality, and to a point now where they actually have a clinical trial ongoing with EVD placement in the emergency room using we're using augmented reality, and they're kind of targeting trajectory tool. And so we'll see how that pans out, but this could be something where you see a patient in the ED, you put on the glasses, you do your 2-minute registration, and then you place it. Instead of taking 1 or 2 or 3 times to place the EVD, you always get it in one. Obviously, the market share has exploded in this area. I mean, this is from now like 4 or 5 years ago, the market share, and it's just kind of exploded. And there's no question that in spine, I don't have to tell you. I mean, you guys are already using it almost every day in cases with most of the spine attendings, and in cranial, I think that this is going to be an area where you're going to see significant growth. Now, how much does this really make the surgery safer, more efficient, and make it an efficacy or major change for our patients? Well, we did this review recently, and we said that, yeah, that there's still kind of some hesitancy of how much true benefit over traditional navigation sequences in cranial neurosurgery there are, because the navigation systems we use are such in tune into our workflow. But I think where the benefit really lies is, again, the future, where we're going to be in 25 years from now. And so, not to be negative on vascular neurosurgery, but I would say, vascular neurosurgery probably has the least amount of technology in it when we look at all the areas of neurosurgery. So if we apply something like this to vascular neurosurgery, what would that look like in 25 years? Well, so this is a case of a ACOM aneurysm. We're exposing it here. And if you had your augmented reality system, you could actually have it do visual recognition, and it'll be tracking all of your cases. So we'll have all of your data, and you could ask it, okay, like, tell me the data on this aneurysm that I'm seeing right here. And it'll basically identify it and say, oh, this is a posterior projecting ACOM aneurysm, and it'll identify it for you. It'll tell you either your own data and say, well, you have a 20% chance of changing your clip after the ICG run on this specific type of ACOM aneurysm. And so it'll kind of give you a heads up of what your own data is, because it'll have been tracking you, and it'll kind of highlight, okay, these are the areas that are most critical. What is your rupture rate? What is your clip time that you normally take with this? And so before you get to the crux of the case, it'll kind of give you the helpful hints. So say you're continuing your dissection, you get to the A1-2 junction, and you're looking at these arteries that are coming out the side, and you say, well, I know one of them's Huebner, but it's unclear what the other one is. And you could ask, hey, Siri, what am I looking at here? And it'll say, oh, well, this patient has an accessory Huebner in addition to the recurrent artery Huebner, which is an anomaly, and it'll identify and recognize it for you in real time, and you could just continue on with your case. When you do your ICG run, we always check to see the patency of the arteries. Well, now you have a second person now that's there that'll kind of check the flow dynamics and the how quickly the ICG will go through each one of the arteries, and can confirm along with you as a second set of eyes that the arteries are patent. So just kind of an idea of, okay, well, if you now overlay this idea of augmented reality during surgery, what can you build on top of that? What does the next generation look like? And you may say, well, that's great, but that's that's pretty far away. And I would argue it's actually not. There's already surgeons that are using visual recognition with AI in surgery. And this is a FDA-approved system by Medtronic called the GI Genius. And so what happens is, as a GI surgeon does a colonoscopy, it actually automatically, the AI recognizes polyps during the colonoscopy and assists the surgeon with biopsying which polyps are more irregular and which aren't. And so it's only a matter of time before this gets to areas, to be identifying tumors, identifying anomalies, recognizing anatomy, and recognizing, how to assist the surgeon in real time during surgery. So, but obviously, I don't do vascular surgery. I do skull base and brain tumors. And so with us, the conundrum is always this oncofunctional balance called with maximal resection and sacrificing neurocognition. And so when we look at the past of innovation in brain tumor surgery, yeah, we have made, again, improvements over the last 50 years, better imaging, intraoperative 5-ALA, made safer surgery with intraoperative neuromonitoring, tractography, and navigation, but it's still limited. There's still a lot of areas of improvement to go with, if I were to ask you, how many cells are left after you do operate, or what is the exact percentage of tumor you left behind, or what is the IQ drop of this patient after your brain tumor surgery? Those are questions that we still really don't have the answers to because we don't really know. And then so one of the things that obviously we've been working on here at is this idea of connectomics, which is kind of looking at beyond the eloquent brain. So we're very good as neurosurgeons with identifying patients that have specific deficits, so a motor or cranial nerve deficit after surgery. But when somebody has a non-eloquent deficit, or that deficit, which would be something like somebody wakes up with confusion or altered mental status, or they have a personality change, or a psychological change with anxiety, depression, or their IQ drops and they can't go back to being the vice president of whatever company they're at. These are things that it's hard for us to predict, as well as hard for us to understand what the recovery is going to be or how to rehabilitate them. And this ability of looking at just not a local deficit, but trying to understand the brain as networks and connections is really kind of where this idea of understanding the brain and ultimately brain tumor surgery will evolve in the future. And so, and right now it makes sense, right? I mean, we have a very complex problems. We use basically a neural examination as well as imaging to try to then predict kind of this very complex problem using 10 data points. And it's hard to really make these appropriate assumptions. So we're underpowered with what we're using right now. We need something else. So when we report and we keep doing these literature analyses, and this is a important point for the residents, we always do these case series and case reports, and we say, oh yeah, patient's intact, GCS is intact, or the modified Rankin scale is intact, and so we'd say successful surgery. But is it really? If we just keep showing pictures of patients being motor, visual, and language intact, are we really doing it justice? So this is a great concept from Alexis Morel, where when we were looking at connectomics, he kind of was saying, oh, we keep focusing on just this and we keep reporting this. And what ends up happening is that we're not paying attention to all the other neurocognitive functions. And if we just keep doing the same thing over and over again, we'll never be able to figure out how to improve memory, creativity, theory of mind, and preserve them during our surgeries. And so instead of just getting a picture of the brain, we really need to understand the functional and structural anatomy. And part of it is just our education. When I was in medical school, we learned about the language system, and we said, okay, it's Broca's and Wernicke's and the arcuate fasciculus. And we've since learned that this is very simplified version of it, right? This is the language network as we now know it, and it was just actually updated in 2021 in neurosurgery, looking at all of the different tracks and parcellations and networks that are associated with appropriate language. And you could have a deficit in language if kind of any one of these kind of areas are disturbed or injured during surgery. And being able to kind of map for that and understand that is something we do now when we do our awake cranies. So instead of looking at just when we look at a left temporal glioma and we look at just awake motor and speech mapping, we're trying now to try to understand, well, all of these networks are at risk, and we need to pay attention to the cognitive changes that could happen if you get into any one of these areas. Now, we've talked about connectomics in the past, so I'm not going to go through all the details here, but just to know that, more about the technology is that, well, how do we do this? Well, we can't just apply an atlas of a normal brain to these patients. You need artificial intelligence. You need large data sets, because our tumors look like this. They're very abnormal, very deformed. And that's where we kind of need to be when we're talking about, their surgeries and their brain connections. So we need to know, for instance, in this patient that has a large left basal ganglia glioblastoma, that the caudate, putamen, and globus pallidus are now moved 4 centimeters anterior because the tumor has pushed it there. And so to understand that this has been moved and validated with AI, makes us rest assured that maybe tumors that before we didn't think were possible to be resected may actually be possible if we understand where the anatomy may be pushed. So yeah, I think you all have heard of the company you've been working with, Omniscient, to look at the functional structural connectivity. We've shown, Alexis and Dan have done a great job showing that we underestimate how many of our patients are really affected at this level. In fact, two times as many have the non-traditional eloquent areas affected compared to the eloquent areas that we typically think. And so this is not a small problem. It affects probably almost 83% of our patients are affected by these non-traditional eloquent areas that are having an effect on neurocognition. So when we think about where we're going with this in the future, we think about, if we look at the functional and structural connectivity and how it's connected, we could start looking at things like hubness, and which is correlated to eloquence, think like path length and global efficiency, which is correlated to IQ, and redundancy and efficiency in the brain. And you could now predict and say, okay, well, if we cut out the frontal lobe, this is the new path that it needs to get to, the central executive node, the frontal node, which would be inferior and anterior frontal lobe. It could still get there, but the path length is longer. And so the efficiency goes down, and therefore his IQ will drop because of that. But he still at least has redundancy to get there. Somebody else may not even have an additional path length to get there. And so you know that if you make that incision, he's just going to lose the function of that anterior node of the central executive network. Everybody's brain is different. And, we're trying to look at that. And one of the tools that we've developed is basically standardizing kind of how each tumor is affected to each network. And so working with Mike Shagru and myself, we came up with this nomenclature. It's kind of similar to like the AVM nomenclature of eloquence, and you assign numbers to how close the tumor is to each node or tract that's within a network. And if you add up all the numbers, the worst outcome, and we're working on validating this now. I'm not going to go through all the examples, but here's like a simple example of maybe where you would think that you wouldn't need to know anything about neural networks or connectomics to take out this left frontal tumor, because it's so close to the surface, it's not a big deal. And you just would say, okay, well, I'm just going to go in there and do a resection. And but when we look at this carefully with with the software that we're looking at, we could see actually very clearly that right here, that the central executive node, the anterior node, which is all this yellow, and let me just stop it. Which is in this area right here, it is actually on this entire lateral inferior border of the tumor. And so you might think, oh, well, I don't want to come very anterior to get to this tumor because of the frontal sinus, and I do a bicoronal crani, and I don't really want to come in this anterior trajectory. I'm just going to come in the lateral trajectory. Well, you're putting at risk the central executive node in the dominant left frontal hemisphere. And so it is worthwhile to make maybe a little bit larger incision, just so you can come a little bit more medial and really avoid this kind of node. Not something you could map intraoperatively. It's just something you could understand if you understand the networks. So I'm not going to go through all the examples here in the lieu of time, but you could see how this could could play, could lead importance. And the question is, how much of an impact can we make with this? I'm just going to skip through it. And can we eventually do theoretical brain surgery? Can you take somebody's functional and structural connectivity and actually plan your surgery and actually predict to the exact specifics? What is their IQ drop? What is their depression status? What is their cognitive change before you even get to the case, and have that risk-benefit conversation with them and how aggressive to be? Or no, are you going to do a lesionectomy? Or are you going to do a lobectomy on this glioma? Or is it a meningioma? And can you take a little bit of brain, or should you always just go through the skull base? All these questions could be kind of answered by using this kind of technology. So, part of this project is validating this, obviously, and trying to understand, we don't really typically understand somebody's depression or their anxiety or their memory to detail when we operate on them. And what we're starting to do that. So we're part of now this multi-institutional trial called the Glioma Connectome Project, which basically gets image neuropsych testing before, after, and then 2 months after surgery, and we get the structural and functional connectivity before, after, and 2 months after surgery. And then we'll go back and do the analysis to see what their changes are, and predict their outcomes after surgery. And not only will this lead towards, changing the type of approaches and surgeries we do, but ultimately it will lead towards restoration of function, right? If you could predict where somebody's deficit would be beforehand, can you begin restoring that before surgery, or know where to target after surgery with things like TMS? And there's some great data that's already kind of come out internationally showing that there are certain areas that are more susceptible to TMS and rehabilitation than others. And you could start subgrouping your patients to the being area. This is an area that we can rehabilitate. This is an area we can't rehabilitate, and making some more upfront decisions as these patients continue to live longer and longer and longer. This is becoming more and more of an important kind of aspect of brain tumor surgery. So what about removing the tumor? I mean, obviously, we now use 5-ALA. We've been using it now at UMH for almost 3 years, and that definitely does assist with resections as well as using your imaging.
And then
But what about intraoperative and real-time updates? And we've, I've already presented this idea of using Raman spectroscopy, so it's not new for me to talk about it. But there's been an explosion of this technology in the last 5 years of intraoperative tissue detection systems and handheld systems. There's in real times that just use a kind of a spectral wave that say yes or no. There's imaging systems like the one that we have. There's confocal imaging systems that take video of the tumor margin. There's laser systems. There's too many to talk about in just a sentence or two, but there's no question that the field is moving towards this idea of having intraoperative real-time feedback on tumors. So, for instance, in our system now, we're able to get these pictures within 2 minutes, whereas before, when we wait for Frozens, it takes 45 minutes, sometimes even an hour to get information. And we could get more information than just, yes, this is tumor, or no, this is not tumor. We could start understanding a little bit more about what does the margin look like. We know that it's rapid, it's accurate. We're using artificial intelligence to tell us not only that it's tumor, but what type of tumor. This was that paper that we worked with Michigan with Todd Holland, and he showed, the top 10 tumor types were able to detect what tumor it is specifically better than the Frozen was able to detect. And now when we operate, we're actually moving towards using AI to actually tell us how much tumor we think are in each specimen. So we have it on our system now that we're trying to work with the team to validate this, that we're actually able to get this kind of RGB visualization where it tells us, okay, in this margin now we have 80 to 90% of tumors within it. And as we march through the margin to normal brain, we can say, okay, here we're actually at less than 1% tumor residual remaining. And you can actually see it visually as you're operating through it. And that'll tell you, if it's an area where you could do a lobectomy or really an extensive surgery because you're in a safe zone of the brain, why not try to get negative margins? But if you're an area where you're approaching eloquence and you're not getting negative margins and it's not clearing, then why would you take the risk to continue to march towards something of not? More interestingly, is where is this going? Okay, that's what we're doing now, but where are we going to be in the next 25 years? Well, actually, yesterday we just had the system updated, and we're working again with Todd at Michigan to look at being able to do molecular subtyping, and so just getting genetic mutations in real time during surgery. And right now, using the taxonomy of the images, they could tell us the IDH status, the 1p19q status, and the ATRX status of a glioma as you're operating, with an accuracy of 93%. And we're working with Todd and Dan on how to validate this in our tumors. And so you might be like, well, why does that matter? Because you're not going to start chemotherapy while you're operating. True, that's a very good point. But the IDH status particular tells us a little bit more about the tumor margins. We know that IDH wild type tumors are more diffuse and have these more finger-like projections, and IDH mutations have more well-defined borders. And so if you could understand how to interpret the imaging and how to interpret the margin that you're seeing, you could kind of make some better assessments and decisions during the actual surgery. And this is a Todd got this funded by the Zuckerberg Initiative, and we're one of the 7 institutions that will be kind of validating his kind of findings that he published recently. What else about intraoperative? And that's kind of the role of robotics in surgery. I think we've definitely used now the ROSA for a lot of our cases where we use stereotactic biopsies, stereo EEG, as well as laser. And the workflow has been improving, and it just kind of shows the synergy of using 2 new technologies, right? We have LIT, which is a new technology. We combined it with robotics, and we've made it that much more efficient. And we published on this that the accuracy now has gone to basically 100% accuracy of getting the laser where we need to without any need to move it. Whereas before it was 90, before we're using the robot, it was like 96% accurate, and now we're 100% accurate over the last 150 to 200 cases, which is like just a great way of showing you that by combining technology and new devices, you could actually kind of synergize them to an area where maybe, you might think that 96% accuracy is enough, but if you get 100%, why not do that? In the future, though, as we start predicting laser ablations of where the ablation zone will be, and we have supervised machine learning to actually understand preoperative factors of where sink areas will be, where the ablation may not be as effective, or where you need to do 1 or 2 more ablations. We actually also just published our kind of innovative solution to larger and more abnormal shaped lesions by using a curved laser catheter, where we could get around structures like arteries, but more importantly, we could treat more unusually and oblongs and kind of different configurations. You can see how in the future you combine all of this apparatus and say, okay, well, it's almost going to be like pushing a button to treat these tumors with laser, and that it'll go in there and it'll create an exact shape, almost like a gamma knife or an SRS radiotherapy, where you could beforehand you make the shape of your radiation ablation area. You could do the same thing with this and just press a button, and it will make the ablation exactly the shape and size that you would want it in the future, with just a push of a button. As we move to postoperative treatment, the question is always, okay, well, what did you do during surgery? Where is the tumor now? How should I radiate it? How big should my radiation be? Is the tumor growing? Is it pseudoprogression? Is it not pseudoprogression? And when should we do the next surgery? And one of the conundrums, especially with gliomas, is exactly that, is trying to understand the radiographic changes that happen in the post-treatment era of brain tumors. And this is some early work that by Dr. Maudsley, and I think this is a case that actually Ashish found when he was a resident, of a really interesting case where this patient had a biopsy that showed a right parietal glioblastoma, even though there's really no enhancement, but there was this flare signal. And he got enrolled in this MR spectroscopy study, and on the spectroscopy study, they were confused because there was another hit in the frontal lobe here. And we went back to the scans, and there was basically no edema. And when they actually followed this patient for 6 months, well, guess what? Unfortunately, this patient developed glioblastoma multifocal centered glioblastoma in both the anterior corpus callosum and the right parietal lobe. And this kind of scan identified that there's 2 areas of concern 6 months earlier. So if we could prove this and validate this, what does this say about the ability to predict glioma presence and growth and recurrence before it actually happens? And will that allow us to change and optimize treatment, change radiation plans, change chemotherapy, et cetera, earlier than not? And so, Chauvin and Cameron presented their data recently of this ability to look at a flare, during surgery or after surgery, and try to say, okay, how much of this flare is just edema? How much of this flare is actually tumor progression? And can we predict this? And so if we know the 6-month scan for this patient, we know that this is where the tumor recurs. It recurs in the posterior aspect of the flare. Can we look at the signature, the metabolic signature of the MR spectroscopy, and try to predict where in this tumor will actually grow and where it won't grow, where it progresses and where it's not progressing? So it turns out you can. So and Chauvin presented this a couple months ago, and then presented again at the AANS, this ability to look at the metabolic ratios of not just the choline and acetylcholine, but all the ratios of the metabolics that we could look at, and look at the signatures, and using kind of artificial intelligence with 84, well, up to now 90% accuracy, using AI model to predict where glioblastoma will recur 6 months before actually it does occur. And so here's a sample case of a patient historically that showed this one has an enhancement and very small amount of flare, biopsy proven GBM, January and March, somewhat stable, maybe a small increase in the flare, but probably not enough to change your management status. Now in July, again, small increase in enhancement, but significant increase in the flare. This is where you're starting to say, okay, this is in the radiation necrosis window? Is this radiation necrosis? Is this not necrosis? Do we start treating? Do we move to a new chemotherapy? What do we do? And it's always a tough decision to kind of make those, even with MR perfusion and some of the other advanced imaging. This is what ends up happening 6 months later. When we look at the MR spectroscopy, the whole brain MR spectroscopy in July, we could see that this is an area of concern much beyond what the enhancement shows within that flare signature. And when we compare it to what actually happens, it compares pretty significantly. And so we should have changed our management in July, knowing that this is where it's going to go. And I would argue that you would actually include, if you were going to re-irradiate, if for instance, if that was the treatment plan, you would want to include this entire margin of whole brain kind of higher ratios from the MR spectroscopy to treat. Ashish had this great idea. Well, why don't we share this with the world? And so our paper that's just being submitted now includes something called the Miami Glioma Prediction Map, which allows anybody to plug in the metabolic coordinates or metabolic ratios and numbers, so that they could actually also use this to, because most people just get a single voxel of MR spectroscopy. You could put in the values of that single MR spectroscopy voxel into our algorithm, and it'll predict for you whether or not that voxel will recur within 6 months or not. And so, for instance, here it's plugged in, and in this voxel, it'll say it's a 93% chance of likelihood of progression in the future in 6 months. So again, what are we doing with that? Well, again, the future is if we could start predicting things with advanced imaging, we could predict how to do better surgery, how to resect better, how to do radiation. In fact, we already have a clinical trial with Dr. Mellon on looking at that, on whatnot. And we could also try to take more tumor markers and do better research and try to understand what is this tumor that is growing in the new kind of growing front of the tumor, and is it equally susceptible to the chemotherapy that we're giving the patient as the tumor that we're resecting at the time of surgery. And Ashish and I are kind of looking into working with a company called Kiatech that is able to actually predict kind of the response of some of these tumors. And we'll let you know how that works out, because it's still in its infancy. So if you think about all these ideas, what's the common ground is that it could all be brought back into the headset while you're operating, right? So whether it be the flow dynamics, the pathology, the connectomics, the mapping, the visualization of the actual anatomy, if you had one main kind of computer system that could hone that in and show you during surgery, that would allow the surgeon to not only get feedback and get information while you operate, but also to track this so that it kind of then reciprocates and updates it in real time. And so when we look at the operative flow of today's world, patient comes in, we do our exam, we get our imaging, right? We really only take 1 or 2 slices of that imaging that we really need during surgery into the operating room. Once we get in the operating room, we get a bunch of other information. We do intraoperative monitoring, we use fluorescence, we use navigation, but how much of that makes it to the outside world? How much of that makes it to the neuro-oncologists and the radiation oncologists and the treating physicians? Not much, really, just the pathology and the post-op film. And so all this data that we're collecting through this patient's course of their hospitalization and their treatment plan is not being really tracked or stored or analyzed. And so when we look and visualize the future, as we incorporate and we use more technology, it needs to be more connected. and to a point of where its data is shared and it's analyzed and kind of fed upon itself to make better decisions. So when we have preoperative radiomics and we have things like where we can tell vascularity of the tumor or anatomical identification and decision making preoperatively, and then you get into the operating room and you get more information about the metabolics of the tumor and the pathology of the tumor, the fluorescence of the tumor, and you correlate the preoperative radiological images to what you're finding in the operating room, that helps build the model and make things more accurate as you go forward. And then it helps guide post-treatment options. And if you say, okay, well, now we're going to treat this based on these images, and we know intraoperatively that this was 5% tumor and it was not the same kind of tumor as the core tumor, the metabolics were different, and we radiated it and it responded. Well, that again feeds into the system of, okay, well, this is now something that we know that we should be more aggressive with resecting, or we should not be more aggressive with resecting because it will be more resistance or not. And then we could validate and develop these biomarkers to kind of then initiate and feed into the circle. So, we've been working with kind of this idea. It's something called TumorNet. It was actually kind of in the cover page article of the University of Miami Medicine spring edition called Reality Check. They talked about all of kind of innovation, the use of AI and augmented reality in all specialties, and this was kind of the one that they chose for neurosurgery. And it's this ability to kind of gather this information while you operate. So as you're looking, can you gather data using augmented reality from the tumor margins and then incorporate into it pathology in the radiomics and the artificial intelligence so that it could be stored in a central database that could then be used for treatment decisions and then be used for preoperative decisions going forward in the future. And so you could see that if you take the SRH and you store all that, and you store the normal brain areas that you found, you store the areas of where you had residual tumor found, and then you could take that going into the future and actually use targeted radiation or understand early prediction and apply MR spectroscopy on top of the intraoperative findings. It'll just make this entire kind of network and data repository more effective. So, which one of these is going to be most important and how to do this is unclear, but I think it's exciting to think about that. I know the spine world has already begun to adapt this. There's several areas with Medtronic and other systems where they're kind of measuring things like intraoperative correction, intraoperative screw placements and rod bending techniques, and then correlating that to walking and functionality after the patient leaves, with the idea that it will feed back into spine surgeons and kind of adjust to them, of really trying to understand how much correction is really needed for patients of different age, different deformities, different degeneration, etc. And we need to start moving towards that in cranial surgery as well. And this is just kind of my imagination of how I think that would work in the future. So in the summary, I think that there's no question that this idea of spatial computing, which is the ability of using augmented reality with artificial intelligence in an interactive world that could give and collect data to the surgeon in real time during surgery, is coming to all surgery, not just neurosurgery. It's coming to all surgery. It has a major impact in the training and preoperative planning because there'll be more rehearsal and more memory and learning, and it's more accessible so that residents and trainees could practice these cases whenever they have time, not just having to go and do it in the lab. As we continue to incorporate artificial intelligence into radiology, preoperative planning, intraoperative decisions, predicting recurrence, and planning therapy, it'll help adjunct the surgeon's decisions to make these kind of at these critical moments of surgery, instead of just relying on your experience, which is equally as important. It'll actually give you raw data to try to make your own personal experience, as well as compare you to the national experience on kind of those key points. And, the integration of all these things of AI, robotics, large data sets, and AR is really what I think will lead to significant growth. And I'm excited to see that happen with the young generation and the residents that are here today, to see where that's going to go in the future of neurosurgery. So the future is you. Obviously, this is many thanks to all of the team here at the UMBTI and the Department of Neurosurgery, the innovation team, the engineering team, computer science team, radiology. It's just been a lot of people really interested in all of these areas, and I thank them for all of their assistance. So I have a couple of minutes left because I figure there'd be some questions from the audience before Dr. O'Phelan gets started.
What do you think will be the first thing that will be adopted, and will it most likely require use of microscope for people who operate like you and other cranial surgeons who use the microscope more versus Dr. Komatar with loops? Like, where do you think that's going in terms of integrating your visual abilities?
Yeah, I mean, great question. I don't think the microscope is leaving us. The heads-up display that I'm talking about and the visual recognition and the onlays, there was one slide that I showed how that would integrate with the microscope, but I kind of went over it quickly in lieu of time. But yeah, it's already being built into the microscope. There are some nuances with the visualization of a microscope compared to seeing it through AR glasses that haven't yet to be overcome. It's kind of like taking something 3D, making it 2D, and then making it back 3D, that you lose some of the kind of that just how well it kind of plays with your eyes and how you perceive things during surgery. That is a little bit challenging right now for the field. And the other field is how much data is too much data. And that's what I think really is the problem with the microscope, because you have a very closed vision of a very narrow field of view, so to speak, which is on purpose, right? Because you're focused in on this one area of working. But I can't look at all of the connections in the brain and all of the pathology data and all the flow dynamics and all that overlaid onto a small field of view at the same time, because it just clutters the field. So that ability to kind of hone in on what's the most important at that part of the surgeon of the case, and then highlight those critical aspects that the surgeon would need, is really what they're focusing on now. And understanding that the surgeon doesn't want to be cluttered with a cluttered field of view with too much information. Understanding what the surgeon needs at what time point is challenging, because different surgeons, I think, require different things at different areas. And there's going to be some ability to kind of quickly toggle between those different key aspects that you would want as well. So there is some kind of learning curve on that area, but that's a great question. Yes.
Okay.
Welcome, Dr. O'Phelan.
Okay, so I know Howard said he was not going to be able to be here, so I can just say a couple words at the beginning and then get started. We are for the next hour, we're going to talk a little bit about some, I guess some people would say, mundane topics, but it's sort of everyday topics that we deal with in the ICU with the neurosurgical patients. And Kelsey and I are going to share the hour. Kelsey, I don't see her on yet, but Kelsey Ladd is our clinical pharmacist on DTC 5 in the neurosurgical ICU. She's been with us for several years. She's absolutely essential to our clinical and research programs. And she has graciously agreed to share this hour with me. So I'm going to talk about, in the first half hour, seizure prophylaxis, and then she's going to talk about anticoagulation reversal. And I'll just warn you that the first 5 or 6 slides that I have require audience participation. So I'm going to come back and look and see what names I recognize. So hopefully the residents aren't just logged in and on mute. So here we go. I'm going to share my screen. Let's see if I can do it. Share screen. Can you all see that?
Yes, go to presentation mode.
Let's see. Presentation mode should be this one. Yeah, there you go.
Correct.
Yep. Okay, perfect. Okay.
We're ready to go.
Yeah, so I'm ready. We're a couple minutes ahead, but I think that's fine. It looked like everybody was there, and that'll give us a little bit of time if it takes a minute for Kelsey. So anyway, so you all know me. I'm Christy. I'm found on DTC5 most days, and have worked with you all for over a decade. And today we're going to talk a little bit about seizure prophylaxis. And I think when most of us think of seizure prophylaxis, it's not the most exciting topic that we deal with on a day-to-day basis. And I think, quite honestly, it's something that we don't give necessarily a whole lot of thought to. And I will say that my experience is that the seizure prophylaxis often gets decided by whoever is doing the admit orders, and decides whether or not we need to check off that box. And also specifically, I think many of us learn seizure prophylaxis when we're in training, and we sort of learn what the standard is, and then we don't think about it a whole lot more. And so as new information is available, or if changes happen in best practice, it's not necessarily something that's in the forefront of all of our thoughts and minds, right? So I think, it's a good opportunity to maybe update our thought process on this topic, and to maybe look at some of the data and rethink our approach a little bit. Okay, so we're going to talk a little bit about the pathophysiology, like why we care about this, the history, which I can give you some firsthand history, and then evidence, the guidelines that we have currently, and then maybe some suggestions for moving forward. And I'm going to try to do that in the first half an hour so that Kelsey has time to teach us about anticoagulation, reversal, the use of TEG, and some of the newer agents that we use as anticoagulants. Okay, so as I warned, my first several slides are audience participation. So, okay, this patient presents with left hemiparesis and neglect, comes in through the ED. Family didn't hear from her, and hasn't seen her for 2 days, and she comes in with this scan. Anybody tell me, do you order seizure prophylaxis? Yes, no. Speak up, or I'm going to go call on somebody.
I think most of us probably would.
You would. Okay. All right. How about this one?
Yes.
Yes, yes, and yes. Okay. 49-year-old female was partying for her birthday, came in GCS of like 5 or 6, got intubated, sedated. This is her scan. Seizure prophylaxis? Yes, no.
I'll answer again. I would say no on this one.
Thank you.
But
Yeah, I really appreciate
you're
it.
welcome.
So yes, yes, and yes. Okay. This one, anybody?
Yes.
Okay, yes, 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 and yes. Okay, and now you operate on this person. I'm assuming it's still a yes. Anybody want to not give the seizure prophylaxis after the surgery? I'm going to assume you all would, because I see the orders, so I'm going to say yes. This person, TBI, GCS of 6, high-speed motor vehicle crash. Yes or no?
Yes.
Yes. Okay. How about this one? GCS of 12, another car crash, TBI. You can see there's some contusions, left frontal, right temporal. Yes, no? Does the GCS matter? How about some of the juniors? You guys write all these orders. Who do I have on here? David, Aman. Alex? All right, anybody want to give this person?
Yes.
I don't think GCS matters.
Yes.
Yes, okay. All right, so that's a yes. So far, yes to
Yes.
everybody. How about this one? Headache with difficulty with speech. And here's the scan. Does this one get seizure prophylaxis? These are admit orders, all of them.
Yes, yes.
Yes, okay. So far I see a trend to yes. How about this one? History of cholesteatoma with multiple mastoid operations in the past, who comes in with headaches and leaking from her ear, comes in for CSF repair. There's her imaging there. Yes or no? This one's maybe a little tougher, but what do you, anybody want to, not want to? What would you guys do? I know what you did.
So this is a day prior to the surgery, right?
This is before surgery, yeah. This is, she's coming in like this.
So I guess no.
You're gonna say no, okay. The first no, one no, a lot of yeses, let's see. Okay, so that's pretty much what we see, although that patient did actually get anticonvulsants too. So all of these people got anticonvulsants. And that's pretty much what we see, is that pretty much anybody that comes in and gets cranial neurosurgery orders, almost always, unless it's like sometimes for like a posterior fossa surgery or suboccipital, we won't, but we do a lot of seizure prophylaxis. And I think that it's, that's a well-founded concern. We worry about these things for a reason. Seizures are not something that we want to have in these patients, especially early on in their time with us. Seizures can be associated with acute worsening, particularly in patients that have an acute brain injury and we believe have vulnerable tissues. So for example, subarachnoid hemorrhage or a traumatic brain injury, we think that their brains are injured by the acute brain injury, and that a secondary injury of a seizure would be, not good for them, right? And then additionally, with aneurysms that are non-secured, we worry that the blood pressure changes and the metabolic demand of a seizure might precipitate a re-rupture, which would also not be good. So we worry about that. There's also in-hospital complications that can happen with seizures, right? So if somebody has a seizure, they may aspirate, they may have hemodynamic instability, they can have cardiac problems associated with that. And then the long-term outcomes, I think we worry about post-traumatic or post-acute brain injury epilepsy. And I would argue that that's probably not 100% related to early seizures, but we think about that stuff when we decide about seizure prophylaxis. So what we do know, and these data have been around for a long time, for over 20 years. This is a paper from 2007, but I think we knew about this even in the late 90s, early 2000s, that seizures in patients with acute brain injury can be or are associated with other types of secondary brain injury, usually associated with increased metabolic demand at the time of the seizure. So for example, these data are from the UCLA group. These are TBI patients that had ICP monitors. And they looked at patients that had seizures. So Paul Vespa's group does long-term monitoring, continuous EEG on all of the TBI patients for several days. And so he was able to prospectively look at the group of patients that had seizures and the group of patients that didn't have seizures, and then just compare their ICPs. And not surprisingly, the patients on the top here are the seizure group, and the patients on the bottom are the non-seizure group. Otherwise, they're pretty equivalent. They're TBI patients that came into a trauma center. And what he found was that the patients that had seizures had more elevated ICP, which we know is associated with worse functional outcome. He was also able to show that there was cellular stress in these patients with seizures. So we did microdialysis in a lot of these patients. And if you look at the ratio of lactate to pyruvate in these patients, you can see that the cells become distressed and are not able to respond appropriately to the metabolic demand that's posed by the seizures, right? So you're putting already injured tissue under the stress of having a seizure. And this was really the holy grail for the first, for my whole training, was you want to do things to mitigate secondary injury and avoid increased stress to tissue that's already injured. And so seizure prophylaxis is a cornerstone of that. And I think that that's still true today. It's just that we've found that maybe seizure prophylaxis isn't A, as effective as we thought, and B, as benign as we thought. And so that's really what I'm going to spend the rest of my 20 minutes telling you. This is a more recent paper looking at patients on Topiramax. And these are just epilepsy patients and patients not necessarily with acute brain injury, but that were on topiramate. And topiramate is one of the newer anticonvulsant medications that is used, probably not one of the ones that we think of as having the most CNS side effects. So when I think of like what anti-seizure meds cause the most problems with cognitive function, I would say phenobarbital, Dilantin, some of these older drugs, but then we see it all the time, certainly with levetiracetam and often with lacosamide. We see patients that are very drowsy after we give them these medications. Topamax is oral only and probably not one of the ones that I would have chosen, but they actually carefully looked at neuropsychological testing for these patients and looked at working memory, verbal fluency, comprehension, reaction time, and really showed the Topamax group is the dark blue, and the percentile functioning is on the y-axis. And you can see that the group that did not have Topamax and really did do better on all these things. So I think it's safe enough to say that all of these anticonvulsant medications can have some effect on cognitive functioning. There certainly are individual differences. Some patients respond differently to one medication versus the other, but all of them probably have some effect. This is another paper that was published in 2014. These are TBI patients treated. When I trained, everybody got a month of Dilantin. So subarachnoid hemorrhages patients that came in got a month of Dilantin. TBI patients got a month of Dilantin. People just decided, well, a month sounds like the right number, and Dilantin is the IV medication that we have aside from phenobarb, and we think Dilantin's better, so why not use it? So some of these earlier studies are done predominantly on patients who are on phenytoin. And what they looked at were patients who were on the phenytoin versus not, and they looked at hospital length of stay, Glasgow outcome score, and the modified Rankin score. And there was a significant difference in these patients. And again, this may not be an absolute one-to-one generalization for what we do now, because typically now we use a week of Keppra. But I will argue that sometimes that treatment gets extended beyond the week for kind of soft reasons. And I would urge you to think about these data that really show a difference in hospital length of stay, in your outcome scale, And I believe the outcome scale was at the end of discharge, and the MRS was like at 3 or 6 months. And so it's a lasting effect on cognitive outcome and functional outcome after acute brain injury. Additionally, this is a paper that's quite old now. It's 2005. This was out of the subarachnoid hemorrhage registry at Columbia University. And this group looked at functional outcome at 3 months, and they looked at what they called the phenytoin burden. And that just means your level of phenytoin, because we would measure levels, and the number of days that you were on it, right? So were you on it for 7 days, 14 days, a month, whatever. And so the area under the curve was your phenytoin burden. And there is an absolute association with cognitive outcomes. So TICS is the telephone assessment, I think, of cognitive scale. And it's they did telephone follow-ups with all of these patients at 3 months. And they looked at, and included in that scale is verbal memory, working memory, language, functional markers, being able to take care of yourself. Like it's pretty broad. And they found a very clear association. The longer you've been on Dilantin, the worse you were doing. And this was corrected for your Hunt and Hess, your Fisher scale, and your in-hospital complications, right? So it took into account who had delayed ischemic deficits, and how bad your aneurysm, subarachnoid hemorrhage was to begin with. So we've known about this for quite a while. And I think this was one of the things that kind of pushed people to find something different from Dilantin and really helped people transition from Dilantin to Keppra. And so then this study, Lori Shutter's group looked at this at 2010 and basically showed that when you look at in seizure patients, you look at seizure frequency in patients with TBI and subarachnoid, basically levetiracetam was equivalent to Dilantin when you look at efficacy. And this was a very helpful paper because it helped people transition away from Dilantin, because prior to that, Dilantin was kind of the mainstay. It was in all the guidelines. It was what everybody used. And we were showing that it was probably not very good for our patients. So everybody thought, okay, now everything's going to be better because Keppra is this new magic drug. It doesn't have drug-drug interactions. You can give it IV. You don't need to look at levels. It must be a wonderfully benign drug, and let's give it to everybody. And we pretty much do. We give a lot of Keppra to a lot of people. And then, as time went by, we started looking at, I think there are actually side effects. So this is a chart from a Lancet Neurology paper that recently came out, and I thought it was a nice way for you guys to look at all of the side effects. So there's adverse reactions, cautions, and side effects for all of these anticonvulsant medications. I put the arrows on the left. The big arrows are the levetiracetam and lacosamide, which are the ones that we probably use the most. But we also use valproate, Topamax, carbamazepine, not infrequently. And these medications have significant side effects, and the significant side effects may be worse in some people than others, but they really are present. And I think one of the things that we worry about sometimes is we have patients, especially like a poor grade subarachnoid or a TBI with a low GCS. And they come in and they may be elderly, and we give them a pretty hefty dose of anticonvulsant, and then they're not waking up. And I think often we assume that they're not waking up because of their acute brain injury. And I am going to suggest that there are probably some times that we're incorrect, and that they're not waking up because we've given them a lot of an anticonvulsant that they're not tolerating very well. And in those cases, it may lead us to inappropriately think that their prognosis is poor, when maybe it would be better. And so we need to be aware of that, and we need to check ourselves a little. And we have continuous EEG monitoring available all the time. We're very fortunate to be able to do that in our unit fairly easily. And so it is possible to monitor these patients and to make sure that they don't have seizures occurring and be able to de-escalate some of these therapies in a way that we can better assess the extent of their acute brain injury and maybe do a little bit better at prognostication and goals of care, etc. So when I was putting this talk together, I was like, well, what is the actual seizure incidence in these different diagnoses that we treat? And it was really interesting, actually. I looked at many different sources. This is a review paper that I've referenced at the bottom, but in general, it's about 20%. So it's about 20% all across the board, right? So TBI about 15 to 20%, depends on who you read. Subarachnoid hemorrhage, 18%. Ischemic stroke, I was surprised, was up to 25%, but it's definitely like it's more associated in the patients with the hemorrhagic transformation, if multiple lobes are involved, or a cortical location, obviously, rather than the subcortical. But the guidelines for ischemic stroke for many years have dissuaded people from using prophylactic anticonvulsants. ICH, again, 20%, and supratentorial craniotomy, 15 to 20%, depending on the pathology, right? So I was surprised by that, because I would have thought that TBI subarachnoid would have been higher, because those are the ones that we use the anti-seizure medications sort of religiously, but it's not true. It's about the same across the board. I think one of the things that is a little bit harder to get your brain around is that even though we know that the seizures occur to about 1 in 5 patients, we don't have great evidence that giving people seizure prophylaxis in the first 7 days actually makes that a whole lot better across the board. We have moderate quality evidence in TBI from a very old paper now that Nancy Temkin did in traumatic brain injury patients that was published in the New England Journal, and basically got seizure prophylaxis into the TBI guidelines. And that they were able to show in that specific population that 7 days of anticonvulsant therapy did affect acute incidence of early seizures. So seizures in the first 7 days. It didn't necessarily, in that trial, make a big difference to late post-traumatic epilepsy. So just because you treat the early doesn't mean you're going to affect the development of epilepsy a year after TBI, which is maybe a little counterintuitive, but that's what the data showed. And if you look through the literature, there's not a whole lot of other evidence that early prophylaxis is actually efficacious. And we have shown that there are harmful side effects, right? So maybe we need to rethink kind of how we do this. So I started looking at, okay, what is the evidence in post-craniotomy? So this is a Cochrane library study. It was published in 2018. It looked at post-craniotomy, trials in neurosurgery for post-craniotomy seizures and early prophylaxis. And you can kind of see here, the quality of the evidence is quite low. So many of these publications were not controlled. They were case series, or they had like significant bias. When you look at the number of participants, they were actually not tiny. It looks like there's early seizures, 5 trials, late seizures, 5 trials, looking at outcome of death. So there are some patients here, and basically 4 of the 5 trials found that there's no significant difference in early seizures with this, prophylaxis. And all of the trials found low numbers of adverse effects, but we have shown that there's cognitive adverse effects. So it depends. If you're looking for cardiac arrest and death as an adverse effect, I agree the numbers are going to be low. If you're doing neuropsych testing on these patients, like I showed you in the topiramate study, that's probably going to be more far-reaching. And it kind of depends on how you look at your adverse effects and how you're collecting them, whether or not you think that that's meaningful. I will tell you that it is meaningful to our patients whether or not they're awake and whether or not they feel like they can function normally. Okay, so aneurysmal subarachnoid hemorrhage, the risk we said was 7 to 18%. We know that risk factors for seizures in these patients, a history of prior seizures, that kind of makes sense, intraparenchymal hemorrhage, infarction. The middle cerebral artery aneurysms tend to have a higher incidence, the thickness of the cisternal clot, poor grade. And like I told you, when I first started training, when I was a fellow, a month, everybody got a month. I think at some point after that, we kind of, for whatever reason, people were like, well, there's this phenytoin study that looks kind of not good. That was like 2005, I think. And so then people were like, well, maybe 14 days is better. And then this study came out in 2007 and really said, you know, I think 3 days is actually as good as 14. And, you know, we transitioned from 14 to 7 and then down to 3 and probably down to 3 somewhere between 5 and 10 years ago. I don't know, I kind of lost track. But I think for at least the last 5 years, we've been at 3, at least in our practice here. And, you know, and I think that is sort of an acceptance of the fact that more is not necessarily always better. And that if we're really trying to prevent the re-rupture and maybe the metabolic stress on vulnerable tissue, that we really don't need some of these medications long-term. And maybe we need to, once the aneurysm secured, really get rid of some of these medications. The guidelines, there's 2023 guidelines from the American Heart Association for aneurysmal subarachnoid hemorrhage, and they look at the quality of the evidence and the level of the evidence and the quality of the evidence and the level of the recommendation. And basically they're saying, if you're fluctuating, you have depressed mental status, do continuous EEG. They'll tell you that if you have a seizure, it's reasonable to treat, but up to 7 days, right? And that is the person that presents with seizures. It's reasonable to give 7 days of treatment. And that there is no benefit and possible harm to treating beyond 7 days. So these are the recommendations from the AHA from this year. And it is also reasonable to not give, if you don't present with a seizure, to not give anticonvulsant and to just monitor the patient clinically or do continuous EEG monitoring. So this is a little bit of a departure, I would say, from what we do typically in our practice. And then we tend to give people 7 days, and then if they're having a complication, we kind of try to limit it earlier. What about anticonvulsant drug therapy for supratentorial meningioma? This is our very own Dr. Komatar, who looked at these. I think this is 2011, and basically he showed there was no difference in early and late seizures in the patients with or without an anti-seizure medication. So we know that. However, we give people anticonvulsants for every craniotomy all the time. I mean, I've never, the only ones that don't get it are the suboccipital cranies. Brain neoplasms. So it matters what type of tumor you have. Primary tumors more commonly than metastatic. Interesting. Low-grade gliomas higher risk than high-grade gliomas. And there are some specific tumor types such as meningiomas, which are thought to be lower risk if you don't come in with seizures. So these data may help us decrease the burden, the cognitive burden on some of our patients that they have from the anticonvulsant medications. Post-operative seizures, risk factors, the periphalcine location seems to be important, and peritumor edema, that is also a factor. So when you're trying to decide which patients may need a longer course, these are the things that you can use. So for spontaneous ICH, there's up to 24% incidence in some series. The lobar location may benefit from prophylaxis. And this was a phenobarbital study in 2002. So there's really not a lot of great evidence for this, but I tried to look for something. So because we tend to, for the AVMs and the lobar patients, we tend to give them a lot of anticonvulsants. But really, when you look for data, there are very few data out there to actually tell you that it's helpful. There's 2 small randomized controlled trials, which looked at the association with anti-seizure medications and outcome, and again, showed poor outcomes in the patients that had more anti-seizure medications on board, and this was from 2009. These are the recommendations from, I think, again, the AHA, looking at spontaneous ICH, and basically, if somebody comes in, you should do EEG monitoring, you should give them treatment if they have seizures, and in patients with spontaneous ICH without evidence of seizure, prophylactic anti-seizure medication is not beneficial to improve functional outcomes or long-term seizure control or mortality. So that's the bottom of that scale there where it says no benefit. So our guidelines are basically telling us not to do this. Ischemic stroke, the guidelines have said not to do this for a long time. And so this isn't new, but this is also another statement from the AHA 2019 guidelines that we really should not be doing prophylaxis, except in very specific cases or patients who have actual seizures. So what should we do with these patients? Well, I think we need to make more thoughtful choices rather than just whoever's filling out the admit orders, just check off yes. I think we need to use our continuous EEG monitoring. If we have a question, if we're not sure, put people on monitoring for a day or two and actually see what their brains are doing. I mean, we very frequently see patients who maybe had something weird overnight and the night team puts them now on 1.5 grams of Keppra because we're not sure if it's a seizure. That's probably not the best thing for that patient. You probably need to look with an EEG and figure out if you think that really was a meaningful seizure risk. And then limit our prophylaxis, particularly if there's compelling side effects, or if no compelling high risk for seizures, we need to limit our plans. So that's the end of my half an hour. If you guys have questions, I think probably we can wait until the end if you guys want to ask questions. Otherwise, I'll hand it over to Kelsey. I saw she was on here. Let's see. I'm going to. I think I can stop share. Kelsey, can you share your screen?
Yes.
Sharing. Stop.
Let
share.
me see.
There.
All right. Did I successfully do that, hopefully?
I think so, yeah.
Okay, great. All right. Thanks, Dr. O, for going first. Oh, I'm so sorry. The ER is calling me. Okay. Nope. I'm going to ignore that. I already answered them. So for everybody who doesn't know me, my name is Kelsey. I am the neurocritical care pharmacist here at Jackson. I've been here about the past 2 years, working closely with the neurocritical care team, as well as the neurosurgical teams and stroke neurology as well, for select patients in step-down units. Thank you for having me here today. I am excited to kind of go over our protocol here at Jackson Memorial for what we do for antithrombotic reversal, as well as some of the new and upcoming literature of where reversal is going to go in the next few years, and as well as a brief review of some coagulation assays, most notably what we are now doing in the ICU with thromboelastography. So some objectives today is just to assess reversal strategies for both oral injectable antithrombotics. We're going to review some upcoming research for possible future clinical applications regarding antithrombotic reversal, as well as discuss these coagulation assays in critically ill patient populations to assess coagulopathy. So just to give you a brief overview of the antithrombotics that I will be discussing today, we're going to be looking at warfarin, our DOACs, including our direct thrombin inhibitor, dabigatran, and our factor Xa inhibitors, such as Eliquis and Xarelto, heparin, low molecular weight heparin, our injectable direct thrombin inhibitor, fondaparinux, argatroban and bivalirudin, as well as our antiplatelets, and a brief overview of alteplase reversal as well. So beginning with warfarin reversal, this always consists of 2 medications. since warfarin depletes our vitamin K um, store with its mechanism of action. So ultimately, we always want to be making sure to give vitamin K 10 units as an IV piggyback over 30 minutes. This does have a peak INR reversal about 12 hours after administration, and this is given with the prothrombin complex concentrate, mostly as a bridge for the PCCs, just because of this delayed onset of action. I do want to highlight that oral IM and sub-Q formulations are not recommended in this setting because they do have an even further delayed onset of action. For prothrombin complex concentrate options here at Jackson, we do have Kcentra, Profile 9, and FIBA. Here we do a flat dose of 1,500 units IV. This fixed dose of 1,500 units across the literature has really demonstrated to be non-inferior to the standard weight-based dose and INR dose that used to be a lot more complicated with calculating that dose. So we just moved to that flat dose here. This does only have a duration of effect about 6 to 8 hours. And we can offer a redose option of that flat dose if needed for an INR of greater than 1.4 on recheck, which should be assessed about 30 to 60 minutes after infusion. So here I just want to highlight kind of the pharmacokinetics of some of our reversal strategies for warfarin and why it is so important to give that vitamin K. As we can see with FFP, PCC, and our recombinant factor 7, which have historically been used for warfarin reversal, you do get that rebound increase in INR at about that 6 to 8 hour time mark. So there have been a few cases here at Jackson that only PCC is given, and we'll see about 12 hours later, ultimately needing another dose of PCC, as well as the vitamin K at that time. So always make sure up front we're giving both of these medications simultaneously. I do want to highlight our different PCC products here at Jackson and why you may lean towards one over the other. So again, we have the Profile 9, Kcentra, and FIBA. Just looking at which factors these products contain, our 4 factors both contain 2, 7, 9, and 10, while our 3 factor just contains 2, 9, and 10, and our activated version of FIBA containing that activated factor 7. I also do want to highlight here that Kcentra is our only product that does contain heparin. So this is just really important. We actually had a case earlier this week with a potential possible history of HIT or HIT that Kcentra should be avoided in these patients since it does contain trace amounts of heparin. Next to review dabigatran reversal, we have Praxvine. This is just dosed as 2.5 grams for 2 doses given about 15 minutes apart. This does have a duration of about 24 hours. Additionally, I don't have noted on this slide, but if following that duration you are concerned for delayed action of dabigatran, this medication is also dialyzable. So you can offer acute hemodialysis to help remove any residual medication if desired as well. And then we can also consider FIBA for these patients, which is our activated PCC at a dose of 25 units per kilogram. And this can be given, again, if there is ongoing or life-threatening bleed. Next, I'll move into our factor 10A inhibitor reversals. I do want to preface this section by saying this is an extremely controversial topic with very many different opinions. I'm just going to be reviewing kind of what we do here at Jackson and why we do what we do, because we do practice differently than UMH, and kind of what the trajectory is for where we're going with factor 10A inhibitor reversal here at Jackson as well. So looking at some of our current reversal literature, here on this slide, I've included a bunch of single-arm studies for your reference. So on the far right, we can see the infamous or famous Annexa-4 trial. This is a single-arm trial, and the rest are single-arm trials for our PCC products. All of these, with the exception of one, I believe, are prospective studies. They looked at different bleeding sources, ICH versus GI are listed here for your reference, and then the hemostatic efficacy of these agents for factor 10A reversal. They also looked at rates of venous thromboembolism as well as mortality. And as you can see, there is largely kind of across the board of these trials, at least, no significant difference between our 4-factor PCCs versus andexanet alpha. Another limitation of Annexa-4 that I do want to highlight while I'm still on this slide is that there are some key exclusion criteria in this trial in comparison to the PCC trials, including ICHs with a score of less than 7 on the Glasgow Coma Scale, as well as an ICH volume of more than 60 ml, which are kind of two of our most high-risk patient populations, as you might know. So that's a huge limitation of the Annexa-4 trial that we do not have data for. Overall, there have also been a ton of retrospective trials assessing 4-factor PCC versus andexanet alpha. And across the board in most of these trials, we really see that they have been shown to have similar efficacy in multiple trials. There are about 2 to 3 trials that do report andexanet alpha to be superior, but I do want to highlight the one that is most commonly referenced that had showed that in a retrospective analysis does have the second author as being the same as the first in that Annexa-4 trial. So as you can imagine, some bias going into that piece of literature. Also wanted to briefly review some practical considerations of 4-factor PCC versus andexanet alpha. So andexanet alpha is our only FDA-approved medication for the indication of factor Xa reversals. So our 4-factor PCCs are off-label. This did lead to an update in the ICH guidelines to recommend andexanet alpha as a 2A recommendation over the 4-factor PCCs being a 2B recommendation. So that's something we should keep in mind since that is our only FDA-approved agent. Administration-wise, Kcentra is much easier for nursing administration. It's just a 15-minute infusion versus Andexxa being an IV bolus with a 2-hour infusion option. Then looking at compounding, thinking of a pharmacy end, I do want to highlight we do only have 2 pharmacists overnight here at Jackson Memorial that cover 1,500 beds. So thinking of compounding something like a 1 to 2 vial dose for Kcentra versus 5 to 9 vial per dose for andexanet alpha is also a huge rate limiting step. There have been some retrospective trials that even showed the time from order entry to administration of andexanet alpha has been closer to about 3 hours just because of this inconvenient compounding method. Then looking at duration of action, we do have a little bit longer duration of action with 4-factor PCC. We did see in the Annexa trial that anti-factor Xa activity did increase to placebo levels about 2 hours after the dose was finished infusing. So we don't know clinically, I guess, the implications of that rebound effect quite yet. And then last, of course, cost. So our cost of our Kcentra is about $5,000 per dose versus about $25,000 upwards to $50,000 a dose for andexanet alpha. So here at Jackson Memorial, we have decided to stick with Kcentra or FIBA for our factor Xa inhibitor reversal as of now. So this is dosed as 25 to 50 units per kilo up to that total cumulative dose of 5,000 units. We don't currently have Andexxa on formulary at JMH. It is available at UMH, but we are pending the Annexa I publication, which should be coming out in the very near future. So this is ultimately our first prospective trial assessing andexanet alpha versus usual care on the rate of effective hemostasis in ICH specifically. So it'll be interesting to see what that usual care arm consists of. I would imagine most of it would be versus our prothrombin complex concentrates. And then we do know that they updated their primary outcome, which I've listed here on the slide for your reference. I think it's pretty controversial from what I've seen on social media regarding this primary outcome, because this means ultimately somebody could have an initial NIH of 12, increase to an NIH SS of 18, and also have a 33% chance of increase in hematoma expansion and be considered a good clinical outcome in this study. So it'll be really fun, I think, to break down this trial with the neurocritical care, neurosurgery, and stroke neurology teams once it comes out and kind of see where we go from there. Additional future anticoag reversal research includes sirparentag. This is currently undergoing phase 2 trials, and I think a lot of clinicians are excited about this agent because it does bind non-covalently to heparin, low molecular heparin, DOACs, and fondaparinux, and doesn't have any procoagulant activity, which is really unique. Most of our reversal strategies, including Andexxa, Kcentra, all of our prothrombin complex concentrates essentially do induce a procoagulant state. So this is I think a very exciting future possibility for anticoag reversal. Additionally, we want to be looking at laboratory assessments for DOAC reversal. Right now, we don't readily have quantitative assays here at Jackson Memorial, at least, and then our qualitative assays have significant limitations. But there is a potential use of thromboelastography. I know that TEG6 and up do potentially have correlating R and ACT times with the use of DOAC, so that will be exciting to see some more research on in the near future as well. And then again, our optimal factor 10A reversal strategy. So is this our 4-factor PCC products versus Indexa? And also I think some new literature coming out on optimizing our 4-factor PCC dosing for this reversal strategy as well, whether we can move to a fixed dose, such as warfarin, for these patients versus that variable weight-based dosing. Next, moving into some of our injectable medications, so unfractionated heparin and Lovenox reversal. Our reversal strategy is protamine with a max dose of 50 milligrams. Here are the calculations listed on this slide for your reference. I will say protamine is one of our only anticoag reversal strategies. However, that also doesn't induce a procoagulant state though. So if ever in doubt, you can just give the full 50 milligrams without really worrying about kind of overcorrecting since it just binds non-covalently to heparin. Next, we have our injectable thrombin and factor 10A inhibitors. Here we just recommend FEBA, dosed at the weight-based dosing of 25 units per kilo. And then looking at antiplatelet reversal. So we can consider platelet transfusions in these patients. However, I do want to highlight that this may not be beneficial for ticagrelor as it does have reversible inhibition versus aspirin and Plavix are irreversible. So once they're bound on a platelet, they have kind of suicide inhibited that platelet itself. But ticagrelor can kind of just bounce off of your current platelets that it inhibited and bounce onto the new platelets that have been transfused. And it does have a relatively long duration of action. So that might not be the most beneficial, but we are pending bintrafimab studies for ticagrelor reversal specifically. So those should be up and coming over the next few years as well, which would bind specifically to ticagrelor for its reversal strategy. We also have desmopressin as an option for these patients, dosed at a higher dose than our diabetes insipidus dose. So it is weight-based, the 0.3 mics per kilo. And it does have a little bit longer duration of action compared to platelet transfusion anyway, and really hasn't shown harm in vast majority of the studies for platelet reversal. So we can always consider this agent and repeat dosing also every 12 hours for up to 72 hours. Typically beyond that point, not recommended just because you can see a decrease in dose response with multiple administrations for this agent. Next, we have alteplase. Recommended reversal should occur within 24 hours since alteplase administration and if symptomatic from the hemorrhage that has occurred. So we have a few options here. We can use cryoprecipitate to replete the fibrinogen, and you can consider redosing as well if a repeat fibrinogen after infusion of the first dose is still less than 150. We also have TXA. This is now readily available in Omnicells in both the emergency department as well as the neuro ICU. So really easy for nurses to just grab on our floor stock and administer this 1 gram dose over a 10-minute period. And then we also can consider platelet transfusion specifically for patients with platelets less than 100,000, or if they were on antiplatelet therapy at home. Here are just our power plans that we have available at Jackson specifically for reversal. So we have our med anticoagulation reversal that contains all of our factor and prothrombin complex concentrate products. Also has that vitamin K for the warfarin reversal. And then we do have a specific power plan for alteplase reversal as well. So next I'm going to be moving into kind of our assessments of standard coagulation assays versus kind of the up and coming new hot thing in the ICU world at least, which is thromboelastography. So I can't believe I made it to this point in the presentation and hadn't talked about the coagulation cascade yet, but had to include it once just here for your reference. So briefly to review, you can see all these clotting factors and the pathways of the coagulation cascades. So we have tissue factor or factor 3 that's released upon initial damage, and that complexes with a factor 7. And this is the extrinsic pathway on the right side. And this is ultimately going to be what our PT and our INR are measures of. Versus on the other side, once factor 10 gets activated, it kind of amplifies the coagulation cascade for our intrinsic pathway. And this is ultimately what our APTT is going to be a measure of. So when looking at the synthesis of kind of all of these intrinsic coagulants and fibrinolytics, we can see our liver is responsible for the synthesis of the majority of these proteins. So in general, in liver dysfunction, there is going to be a decreased production of all hepatically synthesized factors. And in compensation, our non-hepatically synthesized factor production will generally be increased. So I'll show you an example of that on this slide. So we can see a general summary of these alterations in factor production, which may increase both bleeding and clotting risk, right? Ultimately, the relative deficiency of coagulation and fibrinolytic factors really makes a balanced state of bleeding and clotting risk. And this just becomes very fragile in patients with liver disease specifically. Moving into coagulopathy in trauma, a little bit different. We know that hemorrhage can precipitate shock that causes acidosis and hypothermia that in turn leads to this coagulopathic state, also known as our lethal triad. Trauma and shock can also lead to factor consumption and fibrinolysis. So ultimately, our studies have shown as many as 25% in severely injured trauma patients are coagulopathic upon arrival. And in those injured enough to require MTP, actually, that number has shown to reach as high as 75%. So moving away from these standard coagulation measures, we do have viscoelastic testing, which has become increasingly common. It is used to assess the entire process from initial injury through the amplification of the coagulation cascade and the formation of the platelet plug, and even through fibrinolysis. So ultimately, this results in about 30 minutes here at Jackson Memorial specifically. Regarding the types of viscoelastic testing, there is thromboelastography and ROTEM. We have a rapid form of thromboelastography or TEG here at Jackson. So on this slide, you will see the diagram of a normal thromboelastography or TEG. The diagram represents the normal parameters for clot formation, with the first half of the diagram representing clot formation up to maximum strength. So we can see here at activated clotting time and reaction time are the two parameters that measure the time of clot formation to initiation. And these normally range up to 118 seconds and 1 minute respectively. Next, we have the measures of the clot kinetics and the angle of clot formation, or alpha. K is going to be our time that it takes for the clot to reach a pre-specified strength. And the angle for clot formation is typically up to 80 degrees. Next, we have the maximum amplitude, or the MA of the clot, which represents the strength at which the clot is its strongest. And this typically ranges up to 71 millimeters. And finally, we have our measure of fibrinolysis, or LY30, which just kind of measures the percent of the clot that is broken down after 30 minutes of its strongest point. We do not report this value specifically at Jackson Memorial, because it would take an additional 30 minutes to calculate this value. However, I do want to highlight in our ER, their rapid form of thromboelastography, and through TEG Manager, we do have access to the LY30 through those patients. So looking at some of our TEG-guided transfusion products, they just include fresh frozen plasma, or FFP, cryo, platelets, and then TXA and Amicar. So first we have FFP that contains all of our coagulation factors that are essential to clot formation, listed on the slide for your reference. As elevated INR is commonly found in patients with coagulopathy, a large amount of FFP is often used in these patients for prophylaxis without really any clinical evidence for futility. So it's important to note that FFP does have an intrinsic INR of about 1.5. So really multiple doses of this product really won't lower your INR typically beyond that threshold. A standard dose for a patient is going to be about 4 to 6 units. It is important to note that 1 unit is 250 milliliters. So with an average of like 1 liter doses, caution should be taken in patients with cirrhosis and portal hypertension, because increased volume after FFP transfusion can increase portal pressure, potentially precipitating variceal hemorrhage. And the duration of effect of FFP generally lasts from about 6 to 8 hours. Next, we have cryoprecipitate. It contains factor VIII von Willebrand factor as well as fibrinogen in a highly concentrated form. Cryotransfusions supply normal fibrinogen, and a target level of at least 100 to 120 is typically utilized in the setting of acute bleeding. It's dosed at approximately 1 unit for every 5 to 10 kilos. So a typical dose for an average adult ranges only 100 to 150 mLs, so a much smaller volume than FFP and some of our other products. And the dosing interval generally can be every 3 to 5 days for this product because fibrinogen does have a very long half-life of about 100 hours. Next, we have platelets. They're involved with thrombin generation at the amplification phase of hemostasis and help promote actually the activation of our coagulation factors as well. It's demonstrated that correcting platelets to greater than 50,000 enables adequate thrombin production. So this is typically the threshold aimed for these patients, potentially up to 100,000, of course, in our acute patients with head bleeds that may require neurosurgical intervention. Again, this is going to be a higher volume product. So 1 unit is typically about 250 mLs as well, with an expected increase by 5 to 10,000 per unit. And I think I previously mentioned, but the duration of effective platelet transfusions is really, really short. So just about 4 hours from the end of transfusion. Tranexamic acid and Amicar, we really don't have too much data regarding their utilization, regarding TEG-guided administration and dosing specifically, but TXA is historically more commonly utilized, and it's dosed as the same as the trauma trials, like the CRASH trials, as the 1 gram over 10 minutes, and then a second 1 gram can be considered over 8 hours. It can be used in patients that are undergoing procedures that may be in contact with some of our fibrinolytic fluids that can increase the risk of bleeding, such as any dental procedures and ascites that also contains fibrinolytic fluid. And then our clinical uses really come down to trauma-induced hemorrhagic shock and TBI really early on. So within 3 hours from initial event, and post-procedural, we can consider after things, again, contacting those fibrinolytic fluids such as paracentesis. So here is just a kind of an overview of our TEG-guided transfusions. FFP is most commonly utilized in for our coagulation factor problems when the ACT or the R time are prolonged. Fibrinogen or cryoprecipitate is commonly given when our K and alpha times are abnormal. And then platelets for the decreased max amplitude of a clot, hopefully strengthen that final clot. And in enhanced fibrinolysis, we can consider, again, tranexamic acid. So I do want to highlight some trials in liver disease specifically. So here I've listed 2 trials where they do compare kind of these standard coagulation assessments, such as our INR or low platelet thresholds versus our TEG-guided transfusions. And ultimately, when utilizing these TEG-guided transfusions, we end up with significantly less transfusions, similar rates of survival and bleeding complications, and really no difference in bleeding control as well. Moving into trauma trials, there are 3 trials here for your reference, but some of these actually and have shown a decrease in mortality as well with the use of TEG-guided transfusions in comparison to our standard like INR, PT, PTT transfusion strategies. So when looking at our guideline recommendations, we do have updated acute on chronic liver failure guidelines, as well as our practice management guidelines from the East trauma guidelines. And ultimately, they are both moving away from suggesting these INR as our means to measure coagulation risk in these patients, and that TEG or ROTEM can more accurately assess our transfusion needs. So here's just like an example transfusion guidance in active hemorrhage. Step 1, we always want to be thinking to provide our antithrombotic specific reversal up front if we know that any of those agents are on board. Next, probably moving into our TEG-guided transfusions. And then we can consider repleting our platelets, fibrinogen, and hemoglobin as needed based on our minimum threshold for those. We do want to ultimately limit our elevated INR concern in subsequent FFP administration, since this hasn't really shown to provide much clinical utility as we initially thought. We can also administer in patients specifically with liver disease, vitamin K, since these are patient populations that we think may have suspected deficiency. And then if truly uncontrollable with these strategies, we do want to move into considering concentrated products such as PCC or recombinant factor 7 after optimizing these other recommendations. So just as a brief summary, more evidence is currently needed to determine the role for andexanet alpha here at Jackson Memorial specifically. So 4-factor PCC remains our reversal of choice. The option of a single reversal agent, though, as siraparentag for multiple anticoagulants without inducing that procoagulant state may be the future of anticoagulant reversal. TEC-guided transfusions are associated with fewer transfused blood products and rates of transfusion-related adverse events as well, with similar rates of bleeding control and possibly decreased mortality in trauma patients specifically. And our TEGs ultimately should be utilized over standard coagulation tests to guide transfusions and assess our bleed risk as well in patients with TBIs or liver injury. Yeah, with that, I guess both Dr. O and I would be happy to take any questions, I guess, regarding kind of seizure prophylaxis, antithrombotic reversal, TEGs, standard coagulation tests, or what have you.
Great
Hey,
talk,
Kelsey.
I'm sorry.
No, thanks, and great job. I was going to say Kelsey and Dr. O. My question was a little less exciting. You know, one of the more common things that we deal with are patients undergoing elective surgery, many of which are on Xarelto for various reasons. You know, what is your recommended date of stoppage before elective brain and spine surgery?
Yep. So here at Jackson, we do have peri-op guidelines that we kind of discuss, and I know I've sent them to some of the juniors before, but for the DOAC specifically, Xarelto and Eliquis, for high-risk surgeries, of course, like our brain and spines, 48 hours in normal renal function, but in altered kidney function, I would recommend 72 hours. So creatinine clearance less than about 30, probably thinking about 72 hours before operation.
Thank you.
Great talk, both of you, really informative. My question is more for Christy and the Keppra kind of phenomenon. You know, I just noticed in the last year, more and more patients having this kind of side effect of depression and confusion with Keppra. And I'm just wondering if there's any data that's out there to screen patients beforehand and know which ones we should not be electing Keppra on for these elective procedures postoperatively. It just seems like it's a much higher percentage than expected.
Yeah, so, you know, I looked through the literature. There's not much about screening, and I don't know that anybody has been able to identify like a genetic predisposition or anything. I do think that elderly and lower weight patients, just from our experience, tend to have more difficulty, but certainly those with renal dysfunction would need to be dosed lower. But I don't think there are data out there about like how to choose the people that are not going to do well with it. But I will say that like being cautious about, or maybe being more willing to step people down or to take them off and look with the EEG, you know, really would be my suggestion, is that, you know, if we think that somebody's sleepier than we expect and it's not structural, to really be pretty quick about taking them off and putting them on EEG to just make sure that they're not, that it's not a seizure, but that it's probably medication related.
Okay, so you wouldn't recommend that there's a certain population that you wouldn't even do seizure prophylaxis any further in the groupings of the ones that you've discussed? I mean, you discussed a lot of them already.
Yeah, so I mean, I think if you go by the data, and we can ask Rick, but I think, you know, a meningioma that's not paraphallocine, that's never had a seizure, may not need anticonvulsants, right? And I see Caroline just unmuted herself. So
or at least if you like, depending how much, you know, if it went subpial, you know, or perhaps you look at the flare signal change. Christy, I guess my question, phenomenal talking for both of you, but it's just how do we streamline the process of getting EEG? Because I think sometimes the translation of like, hey, we would like the neurosurgical team would like EEG to the leads being on, at least in my experience, sometimes can have like a 24 to 48 hour delay. Is there like a
Sure.
process, like a streamlined process for us to do that? So
Yeah.
that, because I think that's a great idea to just
Talk to the ICU team. So basically we can get the EEG on within 2 hours usually. But what it requires is that we call the epilepsy fellow, and then they call the tech, and then they get hooked up. I think what ends up happening sometimes is that we're not sure, maybe somebody had, fluctuations, but they're not sure. And the team will say, we want an EEG, but the ICU team doesn't really know the details. And so I think just direct communication about why you want the EEG, then we can speak to the epilepsy fellow, or, you guys can also call the epilepsy fellow, but we are talking to them most days, multiple times anyway, because we have people on long-term monitoring. So, I think maybe just more direct communication with the ICU team to try to streamline that. But we should be able to get EEG on people within a couple of hours if we really think they're high risk.
would it be possible to like communicate to the epilepsy team that like we as a department are trying to de-escalate people so that like they might see like kind of like a rise in this for some period of time, you know what I mean?
Yeah, sure.
And we should be
And-
collecting that data too, because if like you mentioned, the data is so limited out there.
Yeah, I agree. That sounds like a great QI project we could look at.
I have one question for you, Dr. Fallon.
Yeah.
So I have read that, like cortical spread depolarizations can help, inhibiting like generalization of seizures in some patients. Do you think that administering, anti-seizure drugs can inhibit cortical spread depolarizations and increase inflammation? And that may be the reason of why we are seeing worse outcomes in these patients?
So I don't think we know. I think looking at the COSBID and the SD2 trials in TBI, the things that were consistently good at changing the spreading depolarizations actually were hypothermia and ketamine. And I think anticonvulsants maybe a little less so. But I think in those cases, we saw, the idea is that you have less microvascular vasoconstriction. And so I think the thought was that maybe, what they were hoping was that the secondary injury would be diminished in those patients. But we don't have those data yet. I don't think they've published the ST2 data yet. So, I don't know that it's that the relationship's consistent enough to know for sure.
Thank you.
Yep. I will say something, Kelsey, I know that we are looking at TEG in our spontaneous ICH patients. The data are not as well explored, I suppose, or published for this population compared with trauma and liver disease. But for high risk patients, like patients with large hemorrhages or patients who have like a spot sign or have like heterogeneous looking brain imaging, there may be some benefit to trying to use TEG to identify which patients are at higher risk for hematoma expansion, but we don't actually know that yet.
Yes, correct. I'm actually, giving a similar talk to the stroke team in about a week or two to kind of review what our consensus is for our spontaneous ICH patients.
Yeah.
Very limited data.
Okay. Thanks, guys. Appreciate your attention and the invitations to come talk to you. And we'll look forward to looking at this one.
Yeah, thanks, guys.